Next up is right ventricular hypertrophy. So we've talked a little bit about the QRS complex itself and what it's going to look like on the EKG, what it should look like on the EKG, and then we talked about left ventricular hypertrophy. So let's shift over to the right side and talk about RVH. Just like with left ventricular hypertrophy, RVH, right ventricular hypertrophy, is another pressure overload issue. Except the right ventricle, if we think of where it pumps to the lungs and the pulmonary system. So instead of having a systemic kind of pressure issue with right ventricular hypertrophy, we're going to have a pulmonary pressure issue. So pulmonary hypertension, just hypertension in the pulmonary system, is a common cause of RVH, as is pulmonary emboli. So if you've got some chronic pulmonary emboli, it's going to manifest itself, develop right ventricular hypertrophy because the right ventricle is having to work harder here. On the EKG itself, when we're looking for right ventricular hypertrophy, we're going to see that our vectors, our electricity, is directed more towards the anterior and to the right. So we're going to have some kind of right-sided issues. So to diagnose RVH on the EKG, we're going to look at V1 and we're going to look at V2. And that's it. Full stop there. There aren't, 300 criteria like there are for left ventricular hypertrophy. We're just going to look at V1 and V2. And we do this because V1 and V2 are our best windows to see right ventricular hypertrophy. So on the right here is a normal heart. And remember that intraventricular septum depolarizes first, and in V1 and V2 that creates this like little tiny R wave, little positive wave at the very beginning. That's a normal heart. But if I have this enlarged right ventricle, I've got this hypertrophied right ventricle, that means this red arrow here, this red vector, is super big. So what that causes, V1 and V2, instead of this little tiny R wave to begin our QRS complex, that creates this big positivity in V1 and V2 because I've got all these vectors, I've got all this electricity, all these cells depolarizing that I'm looking at. So in V1 and V2, those are our best windows to see right ventricular hypertrophy because they're positioned right there to see this like just huge surge of electricity. And in V1 and V2, so that's where we're looking. I'm looking for right ventricular hypertrophy. Is it there? Is it not? I don't know. I'm looking at V1 and V2 only. Those are the only two leads you need to look at. And what I'm looking for is the R to S ratio greater than 1? And that's kind of a confusing, complicated way to say that the QRS complex is more positive than it is negative. The R wave is larger than the S wave. So looking at V1 and V2, in either of those leads, V1 or V2, is the QRS complex more positive than it is negative? You might have it in both, or you might just have it in one, and that's fine. So V1 or V2, is the complex, the QRS complex, more positive than it is negative? If it is, we've got right ventricular hypertrophy. On top of that, we might see what we're going to call a right ventricular strain pattern. We'll get to that in a minute. But primary criterion, look at V1, look at V2. Of those two leads, in one of them, at least one of them, is the QRS complex more positive than it is negative? You're saying I've got this like biphasic, like weird looking complex in V1, V2. How do I tell if it's more positive or more negative? Well, get those calipers out because you went out and bought them. Get them out and measure the positivity, flip it over, and compare it to the negativity. Is it more positive than it is negative? Yes or no? Use your calipers, please. Another telltale sign of right ventricular hypertrophy is your right ventricular strain pattern. You might see this, but it's not all the time. But if you do see it, it's kind of a telltale sign, right? So ventricular strain, we're looking in our kind of early precordial leads, V1 through V4. We're looking in our inferior limb leads, 2, 3, and AVF, because 2, 3, and AVF have a good view on the right ventricle. So that's where we're kind of looking. And with right ventricular strain, we're going to see ST segment depression with an inverted T wave. And we're going to call that right ventricular strain. If we see ST segment depression and T wave inversion, so a negative T wave in leads V1 through V4, and or the inferior limb leads 2, 3, and AVF. All right, let's look at a couple 12 leads and go through our process. The rhythm itself, normal sinus rhythm. We got a nice P wave. Axis. Let's look at lead 1 and AVF. AVF definitely upright, definitely positive. Lead 1, is that positive or negative? We have to put a tag on it. So do you think it's more positive or do you think it's more negative? If we were to measure that and take out your handy dandy calipers that you bought, it's definitely a little bit more negative than it is positive. So we have right axis deviation. And you're like, woo, I've got right axis deviation. Okay, so moving on, let's move into our ventricular blocks. Do I have a bundle branch block? Well, no, because my QRS complex is narrow. Can't have a bundle branch block with a narrow QRS complex. So no bundle branch block. Well, do I have a fascicular block? Do I have a hemiblock? Well, maybe. I've got right axis deviation. Right axis deviation kind of makes me think left posterior fascicular block, left posterior hemiblock. So I need an S1 Q3 pattern. I've got an S wave in lead 1. I do have a Q wave in lead 3. Look at that. Right there. Right there. Q waves. That's the Q wave sound. So I do have an S1 Q3 pattern. So I'm thinking left posterior fascicular block. Okay, well, there are a couple of rule outs. There's right atrial enlargement and right ventricular hypertrophy are rule outs. So if I have one of those, I don't have a posterior fascicular block because there are other reasons for that right axis deviation. So we're going to look for our hypertrophies. Well, first, do I have left ventricular hypertrophy? So we've talked about that already. Let's look at our deepest V1, V2. Definitely V2. We've got 5, 10, 12, and maybe like 40. We'll say 15. And tallest V6, V5. Looks like V5 might be the tallest there. 5, 6, 7, 8. So 8 plus 15, 23. Don't have that criteria. Do I have any complex that's at least 45 millimeters in and of itself? Negative or positive, so negativity or positivity. Nope, it doesn't jump off the page. Do I have my limb lead criteria? Nope. AVF looks okay. Huh? Is it 5'10"? It's like right at 11. Maybe. Maybe. Yeah, we might be able to call left ventricular hypertrophy with AVF. Or excuse me. Sorry, I led you down the wrong path. We're looking at AVL. AVL greater than 11. Nope. AVF is 20. Sorry. My bad. AVL greater than 20 in positivity? Nope. Lead 1 greater than 12 in positivity? Nope. So we don't have LVH. So no LVH, no left ventricular hypertrophy. But what about right ventricular hypertrophy? And you're thinking, well, it's probably going to be right ventricular hypertrophy because that's this lecture, right? So, hey, look at that. So we look at V1, V2. Is it more positive than it is negative? V2 is a little bit more negative than it is positive if you take out those calipers that you bought. Right? The big like 20 pack of calipers that you bought. V2 is a little bit more negative, but V1 is definitely more positive than it is negative. So we have RVH, and we have a right ventricular strain pattern. Look at that. It goes all the way, actually all the way through V6. We have some ST segment depression. ST segment, the J point is below baseline, and we've got this inverted T wave. If we look at our inferior leads, 2-3 AVF, same thing, ST depression, schmark, and then inverted T wave, same thing as AVF, schmark, right? and then inverted T wave. So we have right ventricular strain pattern. We have an R to S ratio that's greater than 1. There's more positivity than negativity in V1. So we have RVH, and RVH is going to rule out our left posterior fascicular block. So we don't have a fascicular block, but we do have right axis deviation that's being caused by the right ventricular hypertrophy. Second EKG, start from the beginning, rhythm, normal sinus rhythm, or sinus rhythm. I didn't count the beats per minute, so a sinus rhythm. What about axis? Lead 1 is down, AVF is up. What's that tell you? Tells us right axis deviation. So lead 1 is down, AVF is up, right axis deviation. So we're starting to think left posterior fascicular block, left posterior hemiblock. So look, well, I need an S1Q3 pattern. There is an S wave in lead 1. There is a Q wave in lead 3, just a little tiny, itsy bitsy, little teeny weeny Q wave in lead 3. So I've got that. So I'm thinking left posterior fascicular block, but we need to rule out, remember, right atrial enlargement and right ventricular enlargement. So let's move over to our blocks, our ventricular blocks. Do I have a bundle branch block? Nope. I've got a narrow. Oh, it's kind of on the borderline, but narrow QRS complex. Do I have left ventricular hypertrophy? So I take the deepest S wave in V1, V2. Looks to be V2. That's got like 5, and 8. Tallest R wave in V5. So 5, 10, maybe like 13. So 8 plus 13, 21. We don't have that criterion. I don't have any positivity or negativity that is 45 millimeters or greater. We look at our limb leads. Lead 1, positivity is not 12 or greater. AVL is not 11 or greater. AVF is not 20 millimeters or greater, so I don't have LVH. We move on to RVH, right ventricular hypertrophy. V1, V2 is in either of those leads. The R wave greater than the S wave is more positive than it is negative. And yep, in both V1 and V2, it is more positive than it is negative. And we have right ventricular strain pattern again. We've got ST depression with this inverted T wave all the way through V5. Don't have it in our inferior leads, but we've got it here in our precordial leads. So I've got an R to S ratio that's greater than 1 in V1, V2. I've got right ventricular strain pattern. I can call right ventricular hypertrophy, diagnose that from the 12 lead. And that rules out our left posterior fascicular block. So I was thinking that we're going to throw that out the window because we have right ventricular hypertrophy.